Tim here for that presentation. It was very helpful to understand the importance of screening for social determinants of health. And as a little plug for Doctors for Change, we will be soon launching an updated version of an online guide we have to help clinicians and social workers and to connect to services that are available in the community to help address some of the social determinants of health that we touched on. Our next speaker, Nancy Correa. She is a Senior Community Initiative Coordinator at Texas Children's Hospital. She has over 10 years of public health experience, and she is working to bridge healthcare and the community to improve health outcomes. So we welcome Nancy.
Okay, I'm pretty loud, so I'm going to try to not use the mic, but if you can't hear me, let me know. Can we hear me? Okay, thumbs up. If that changes, let me know. So Tim did a really great job of providing kind of an overview of social determinants of health and why, as a kind of health community, it's important. And now I'm going to spend the next 20-30 minutes kind of doing a deep dive into 3 social determinants of health. Kind of when we really get in there, we look at screening, we look at resources. What do we find here in our local community, and what should we do about it? So kind of building off what Tim Weir says, at Texas Children's Hospital, a few years back, really questioned, why treat people and then send them back to the conditions that made them sick? Like, why? What's the point, right? And so we, as Texas Children's Hospital, established a new section of public health and primary care to really look at how do we mitigate these childhood adversities and build resilience in our community. And as part of this section, established some adverse childhood experience work groups where we bring together local government, community nonprofits, academia, and healthcare to look at these adverse childhood experiences and social determinants of health to see where are the gaps and what can we do to either prevent this adversity from happening in the first place or mitigate the impacts. So we currently are looking at 6 different adversities: abusive child maltreatment, postpartum depression, intimate partner violence, food insecurity, perinatal opioid use, and children with incarcerated parents. We go through a pretty systematic approach when we're kind of addressing these adversities, where we go through a pretty detailed assessment to really understand what are the gaps in this area, and then depending what it is the solution a policy solution? Do we need more knowledge? Do we need to do a research study? Do we really just need to scale up some existing services and programs that we have? And then kind of, again, depending what the needs assessment shows, either work with government relations to implement changes, work with our community partners, work with academia to do a research study to then kind of help address those gaps. So today we're going to focus on three of the areas: postpartum depression, food insecurity, and intimate partner violence. So postpartum depression, just a quick refresher. So postpartum depression is a type of depression that occurs during pregnancy or during the first year after having a child. It's associated with feelings of sadness, hopelessness, and guilt. An assessment conducted by Children at Risk a few years ago kind of showed that we have probably between 12 and 15,000 women in Harris County experience postpartum depression each year. And we are very concerned with that because postpartum depression is not only negatively impacting the mom, if it goes untreated, is also negatively impacting that child because they're not having that kind of maternal-child bonding that's really so critical during that first year of life. So we questioned, how do we improve the early identification, referral, and treatment for women with postpartum depression? So we had heard anecdotally we don't have enough services, but we really didn't have any data. So my team and we tried to find every agency we could in the county that offers postpartum depression services and treatment. And at first glance, it wasn't too bad. So I believe this is 17 agencies that offer postpartum depression treatment at 54 different locations. So again, not great, but honestly, I was pleasantly surprised. I thought I was going to pull this up and there'd be 20 dots. But then we started asking some more detailed questions. First question being, do you accept Medicaid? 54% of our moms here in Harris County are covered by Medicaid when they deliver. And so then we jumped down from, I believe, 54 locations to 40 locations that accept Medicaid. As many of you may know, if you deliver on Medicaid, 60 days after the birth of your child, you get kicked off Medicaid and transition to a program called Healthy Texas Women. Healthy Texas Women does offer a little bit of postpartum depression care. Basically, if you have mild postpartum depression, it will provide coverage. If you have moderate to severe postpartum depression, it will not provide enough comprehensive for your treatment. But so once we looked at, do you accept Medicaid? Then we were down to 24 locations in our county. Next, we looked at, can you get in quickly? So do they have open appointments within 2 weeks for new patients? Then we were down to 17 locations. And finally, if you need services in other than English or Spanish, we are down to 15 locations to kind of meet the needs of probably our low-income, diverse moms with postpartum depression here in Harris County. So no, the answer, this was our guess going into this project, but then really had the kind of data to show that no, we do not have enough services to meet the needs of moms with postpartum depression. So simultaneous to our effort of kind of doing this initial assessment, some colleagues of mine at the Pavilion for Women, the Women's Place, received funding for a district project to train all of the pediatric practices in the Texas Children's Network. That's 51 pediatric practices and 260 pediatricians, as well as the 4 OB practices that deliver at the Pavilion for Women to screen for postpartum depression. This started about 5 years ago. It was super exciting. So we got the screening embedded in our electronic medical record. So now all of our pediatric practices are screening for postpartum depression at the 2-week, 2-month, 4-month, and 6-month postpartum visit. This is huge, because what we know about postpartum depression is a lot of times mom won't go to the doctor for themselves, but they're still taking their baby to the pediatric appointment. And we know that postpartum depression, and traditionally this was not done, because the baby is the pediatrician's patient, not the mom, right? But we were able, there's enough research out there that mom with postpartum depression negatively impacts that health of the baby, so we were able to kind of get the buy-in needed. So we now have pediatrician screening at 4 time points. We also have the OB screening twice during pregnancy and once at the postpartum. If mom screens positive, there's a referral through the electronic medical record that goes directly to our Women's Place, which is the Texas Children's Hospital Reproductive Mental Health Center. And if they receive that referral, then the Women's Place actually will call mom to try to follow up an appointment. And as of December, our pediatric practices and OB practices have done 53,000 screens for postpartum depression. 7% screen positive. This is low. We know that number should be a little bit higher. Of that, 72% consented to having a referral. Those who did not consent, a couple reasons. If they wanted medical treatment outside of Texas Children's, that won't show up here. This is just if they did it kind of internally. There still is stigma around postpartum depression, so they may have just declined the referral. And then of those, 64% actually showed up for the appointment. So there's room for improvement here, but this is, if you look at the literature and compare this to others, this is really good. We're moving in the right direction. But the problem is now, like I said, these were kind of parallel efforts. We've kind of confirmed the assumption we don't have enough services to meet the needs for moms with postpartum depression, and we simultaneously are now screening more moms and identifying more moms and referring moms to treatment. So what do? We have a higher demand for services, and we don't have enough services. So the work group, we have some wonderful, brilliant people that kind of came up with this. And ultimately, we decided we need a more tiered model of care for postpartum depression. Right now, standard of care, if you get screened positive for postpartum depression, you are sent to a psychiatrist. Our hypothesis is not all moms need to see a psychiatrist. There are some moms with severe postpartum depression with psychosis, kind of the horror stories. Absolutely, they need to see the psychiatrist. But perhaps for moms with mild to moderate postpartum depression, maybe they would be okay with seeing a licensed clinic social worker. Maybe a home visitation program would be sufficient. Maybe a support group would be sufficient. So we are now implementing, not just getting ready, implementing a randomized control trial where women who are part of at one of the pediatric practices that screen positive, they will get referred either to standard of care, so they'll get referred to the psychiatrist, or they will get referred to our intervention group, which is a home visitation program. And then we'll be studying to see whether or not those outcomes are the same for those two groups of moms. Our hypothesis, our assumption is they will, but before we implement this new program where we're saying, okay, home visitation programs for everyone so we have better care, we need to make sure we're not doing harm first and that the intervention is as effective as a psychiatrist. And I will add, to be eligible for this program, you have to score between a 10 and a 20 on the Edinburgh Postpartum Depression scale, meaning anyone above a 20, they're ineligible. You should go see a psychiatrist. This is just for the moms in that mild to moderate range. I'd also like to add, last May 2017, the Texas legislature passed a bill that requires Medicaid to reimburse pediatricians for postpartum depression screening, which is really exciting because before OBs would be reimbursed, but pediatricians would not, again, because mom is not their patient. So this is really, my understanding right now is this is the second time there are two things that Medicaid, through the child's Medicaid, are reimbursing maternal care. One is breast pumps. So through the child's Medicaid, you can get a breast pump paid for. And number two is postpartum depression screening. I think there could be big opportunities there. I don't know what they are, but I'm trying to plant that seed as many times as I can as we're thinking about the next legislative session. We're doing questions afterwards. Okay, next, food insecurity. So food insecurity, and I'll go quickly through this because Tim Weir kind of provided some background. It's the state of being without reliable access to a sufficient quantity of affordable and nutritious food. 17% of our households are food insecure. That jumps up to 24% for households with children. And as Tim Weir mentioned, the good thing is there are a lot of hospital and clinics that are now screening for food insecurity, which is fantastic. We're kind of moving the needle towards having our healthcare providers looking at and screening for social determinants of health. So what we did is we brought together some of our community nonprofits. Lots of my food big friends are here today. Some of our early adopters that were screening for food insecurity, and our local experts, and really tried to look at, what are the best practices? What have we learned? How should we screen for food insecurity? What resources are out there? So then those that are interested in adopting this have, what are those resource lists? And then made recommendations based on what we found. I do have the URL at the bottom where you can find the report. And quickly, a few of our recommendations. One are providers that were screening said you have to have an buy-in from your leadership, and you need a champion from your clinic if this is going to work. Or if not, you're just going to have really low screening rates. Also, I did a kind of fun little tour of some of our local pantries, and all pantries are not created equally. And I think that's really important. So if we think, okay, I'm going to go to the Houston Food Bank's wonderful website, okay, look, these 3 food pantries are closest to me, I'm just going to print them on a sheet and give them to my patient, I'm done. I would suggest not doing that. Some of these pantries I visited were absolutely impressive. They had urban farms attached to them, so the pantries included local produce right there. They had, all signage kind of encouraging balanced meals and wonderful nutrition education as you went through it. And then other pantries were fully from, donations from a community center, a church group. And so it was really at the whim of whatever donations they got. So maybe they had healthy food, or maybe that week they received donations of Doritos and Pop-Tarts. And so if you have a patient with chronic disease, which we know patients with chronic diseases have higher rates of food insecurity, are we doing good or are we doing harm? And I don't know the answer to that, but the idea is know what your resources are because they're not all created equally. So if you're referring your patients to community resources, there's lots of amazing resources out there, so let's just make sure that we're comfortable with those resources. Also connecting patients with the federal nutrition programs, SNAP and WIC, they actually have stronger evidence that those actually decrease food insecurity and improve health. So we want to make sure we're connecting our patients with these federal nutrition programs. We want to enter the screen into the electronic medical record. That just helps create reminders so we're screening, and then it also makes it easier to track and follow up and make sure with the compliance. Again, focusing on health, not just hunger. Again, are we giving the bag of Doritos or the apples and the whole grains? addressing root causes of food insecurity. The food bank actually has some incredible programming now and some pilots where they're really looking at trying to look at what are those underlying causes of food insecurity, education, employment, transportation, and trying to use kind of their resources to help address those root causes. Next just is evaluation. So this is an area where practice has outpaced research. So we really don't know what, if, again, like I said, if we're screening for patients and we're referring them to a food pantry, is that helping, or is food insecurity just such a symptom of poverty and it's just kind of putting a Band-Aid on a much bigger problem? Is it making a difference? Or is it truly that is what's getting them through the month now, and that was such a wonderful, huge help for that family? And the answer is we just don't know. So we just need more research so that we know that what are these programs, what are the impacts of this programming, of these referrals on our families, so then we can continue to do better and be offering effective programs to our families. So based on that, with really kind of an emphasis on the need, we don't know what works. As we all know, for the providers in the room, are very, very busy, right? So if a simple referral sheet is effective, then that's incredible. Then let's stick to that. There's no need to be doing more intensive interventions. If giving a family a referral sheet does nothing, then that's a waste of time, and then we need to be doing a more intensive intervention, right? That actually decreases food insecurity and improves health. So we have submitted a grant to HRSA in partnership with UT School of Public Health. It's under review right now. I think we find out actually next month whether or not we get funded. So essentially, we have one clinic that'll be screening for food insecurity, and then they'll be getting a resource sheet of kind of local resources. And then we'll be following them up for a year to see how their health changes and how their food insecurity changes. At our second clinic, they'll be getting screened, they'll be getting a resource sheet, and then there'll be a patient navigator that'll actively work with that family to make sure they're getting the resources they need, that they're getting signed up for those federal nutrition programs. And then at our third clinic, they'll be getting all three of these, plus a prescription, food prescription for a local pantry with 20 pounds of fresh produce. So the idea here is that clinics, because clinics are so busy, we want to do whatever level is minimally sufficient to improve outcomes. So if arm one is sufficient, just the resource sheet, that's amazing. If it's not, though, we need to know that so our providers can be doing interventions that actually improve the outcomes. Am I making sense? Yes, okay. Had a couple blank stares. I wasn't sure if that was because it's 7:30 at night or because I'm talking gibberish now, so that's good. Also, want to make sure, I feel like this is one of the best kept secrets in Houston right now. Please take a picture so you can get the URL at the bottom. This is an incredible resource developed by the UT School of Public Health that was just released in the last couple months. So it's called the Houston Area Food Access Analysis Tool. So this is an online map with lots of layers that you can play with. The red is the food deserts. And then the brownish circles are actual data from food insecurity screenings being conducted at our local hospitals. And so what's interesting to me here is you see some overlap, but you also see a lot of those brown circles in areas without food deserts. And I think, this data here, I believe this is November data. So this is, I'm guessing this was true pre-Harvey, but I'm guessing is even more true post-Harvey, that food insecurity is not isolated to food deserts. When we look at Houston, we see it in pretty much every zip code, right? So as we're thinking about, food insecurity, and we know, again, 1 out of 4 households with children are experiencing food insecurity, that we really need to be looking at kind of community-wide and system-wide solution, not community neighborhood specific. Okay, and finally, we're going to jump into intimate partner violence. Can I see a show of hands who has received any sort of training on intimate partner violence before? Okay, about half. So for those of you who did not raise your hand, and even those that did, these slides may be tough to hear. I will have resources at the end. If this triggers anything for anyone, I'll also be available at the end. And again, feel free to leave, because like I said, this is a tough topic if you have not been exposed to it before. So intimate partner violence, it's a pattern of coercive behavior that is used to control someone. It includes physical, emotional, financial, and sexual abuse. Nearly 1 in 3 women and 1 in 7 men experience intimate partner violence at some times in their life. And as healthcare providers are recommended to screen for intimate partner violence, pretty much the AAP, the ACOG, Academy of Family Physicians, Joint Commission, U.S. Preventative Services Task Force, all recommend that we screen for intimate partner violence. However, despite these recommendations, as a general rule, screening rates are very low in the healthcare setting. So the question our work group asked ourselves is, so how do we improve screening for intimate partner violence and connect victims with resources? So we conducted our assessment. We did a literature review. We did 26 interviews with healthcare organizations, with shelters, and our local experts. And then honestly, at that point in the assessment, we still didn't know what to do. And then we did 3 focus groups with survivors of intimate partner violence, and they really opened up our eyes where in the Houston-Harris County the healthcare sector is missing the ball and where there's opportunities to improve. So locally, there is no consistency in screening, both within institutions and between institutions. I would talk to one person at a healthcare organization who would show me this beautiful protocol on screening for intimate partner violence at their hospital. And then I would talk to the nurse, and they would have absolutely no idea what I was talking about. And I was like, with the purple binder! Have you seen the purple binder? And I kept hoping that, I would find the answer, but truly, and then plus, a lot of this is not being tracked well in our electronic medical records. So even those with these beautiful protocols that I was so excited about, when I asked them, okay, how's it going? Are your providers screening? Are the women disclosing? What are you finding? And then they just, we think it's going well. We hear good things, but really, there's no data to show it. So then, like I said, ultimately, do the focus groups and really identify 5 themes. In the interest of time, we're really going to focus on the 4th theme, which is really around screening in healthcare settings must be improved to effectively identify and refer IPV survivors. So the first lesson was screening alone. That sounds very obvious, but of the 17 women I spoke to, about half of them had been screened for intimate partner violence. Not a single one was screened by themselves. Every single one of them was screened with their abuser sitting or standing right next to them, so they didn't have the opportunity to disclose the abuse. You can't even signal to them because it's scary. It's like you're being held hostage. You can't tell nobody. It's hard to fill out forms when they are right next to you, watching you. Number 1, you have to admit to yourself that there's a problem at home, and you don't want to do that. Number 2, they're right there next to you, and you're like, no issues. Second, they talked about wanting to know before you screen them, what are you going to do if they say yes? There is so much fear really focused around 2 things. 1, losing custody of their children, and 2, their abuser finding out and there being retaliation for disclosing the abuse. So they really emphasize, I need to know that this conversation is going to be private. I need to know what you're going to do if I disclose the abuse, because I have so much fear of my abuser finding out about that disclosure. The screening was routine. They would ask, do you feel safe? If I say we're not okay, what happens next? They couldn't see past the next question. I never felt okay saying yes. I didn't know what would happen. The next was just a general needing to improve rapport between our patients. And interestingly enough, in the middle of this assessment, I was at my annual physical, and I actually was screened for intimate partner violence, which I was very excited about. But the way I was screened, I know that sounds funny, right? I was like, oh. It was a nurse practitioner in my case. Her back was to me, so it was like this. She was washing her hands, and she said, you feel safe at home, right? So, I mean, how are you going to respond? You know? So they talked about making eye contact, listening, just feeling cared about as being really critical to them being comfortable disclosing. the providers hardly even look up at you. They don't care. They need to be retrained to ask the right questions. Which leads into our next question, more specific questions. So it was really interesting. Many of these survivors were in abusive relationship for years before they identified it as abusive. One quote that's has stuck with me was, he pushed me and he shoved me, he hit me. It wasn't anything I couldn't handle. It wasn't until he threw an axe at my head that I realized something was wrong. So just a very, very high threshold of kind of tolerating kind of these unhealthy relationships before recognizing. And they also really emphasized how harmful the emotional abuse was. And for many of the survivors I spoke to, the physical abuse, they're like, yeah, that I could recover from, depending on it, a day, a week, a month. But the emotional abuse is what sticks with you for years and years and years. So really emphasize the need, because I think, and I was guilty of this too, when I hear intimate partner violence, I immediately think physical abuse. And they were really emphasizing the need to kind of change our kind of paradigm and perception of intimate partner violence and not forgetting about the emotional abuse as well as financial abuse. One of the women talked about how, she worked, she'd have to sign all her paychecks to her husband. Her husband would pay his bills, but wouldn't pay any of the bills in her name. So then she had terrible credit and no money. So how are you going to leave a relationship if you have no money and terrible credit? What are you going to do? And you're also isolated because that's part of the cycle. I did not know. I really thought it was the norm. It didn't hit me. I knew it wasn't right, but it didn't hit me that it was abusive. And then finally, it was just a reminder in our, if a woman or man does disclose abuse, that we need to have, that we should not have a one-size-fits-all follow-up process. Because we had really interesting conversations and debate on the best way to follow up. And just depending on that individual, they all had different preferences on what was the safest way to communicate with them after they left your office. Some would say, oh, email's great, and the next one would be like, oh no, the iPad's connected to the MacBook, which is connected to my phone, so he may see in the other room before I even know. So just really emphasize the need of, taking in mind the patient's communications preferences and follow-up and making sure we are very strictly following them. And finally, as when we went into this focus groups, I actually was kind of trying to get out of the healthcare setting. After doing the literature review and talking to everyone, I was like, what, maybe the healthcare setting is not the right place. Maybe I should be talking to churches, and maybe I should be talking to hair salons, and maybe we just need to completely kind of start over, and we don't have it here in the healthcare. But we've talked about a lot of ideas, and ultimately the only place they all agreed on as where they'd want to be screened and where they'd be comfortable disclosing was at the OBGYN. That was kind of the strongest recommendation on where they thought screening and disclosure should take place. They also we did not ask a single prompt around pregnancy, but 16 out of the 17 had children, and 16 out of the 17 shared stories of abuse being worse during their pregnancy. Several of them, in their mind, had miscarriages, which they attributed to the physical violence that they experienced while pregnant. He beat me up when I was pregnant, and no one knew. The OB, pediatricians, and all of them didn't know because we look regular. They never asked if I was okay. When you're pregnant, the abuse gets worse. Gynecologists, I could have probably been open to respond because the abuser, couldn't see or know what I was answering. Again, increased opportunity to be alone. And when you're pregnant, you're going to see, initially seeing the OB once a month, towards the end every 2 weeks and every week. So you just are seeing a healthcare provider a lot more often than any other time period in your life. And there's also that opportunity to build that rapport. And you're already talking about pretty sensitive issues, very personal issues when you're seeing an OB. So it's not quite as far of a stretch of, do you exercise, does your husband hit you? There's already kind of that comfort level enough, those sensitive questions. So where are we now? So based on these findings, we published a report and developed 15 recommendations on how to improve screening for intimate partner violence. And honestly, in the past 3 weeks, if I had given this presentation a month ago, I would say that we were stalled. But now I can say we've had so much progress in kind of meeting our recommendations. So First, at the Centers for Children and Women, they are 2 clinics that provide OB, pediatric, and behavioral health for Texas Children's Health Plan and Medicaid provider patients. So they agreed to basically follow all of our recommendations from our assessment and to pilot this to see what happens, what are our screening rates, and do we have higher disclosure rates if we're really following the advice of the survivors. So that pilot went live April 23rd. When kind of consulting with their providers, what we did is we added the IPV screening protocol to their current protocol for postpartum depression. So they said, we're doing pretty good with postpartum depression, we have high screening rates, our providers are comfortable with it, so let's start there as opposed to like starting from scratch. So the OBs are screening 3 times, the pediatricians are screening 2 times. We had a huge delay. Like I said, if it was a month ago, I would have said we've been very stalled because in figuring out how to enter this in the EMR, because in a pediatric practice, mom and dad have access to the baby's chart. So if the pediatrician screens mom for IPV, gosh, this is a tongue twister, and she discloses abuse, a week later, 10 years later, dad could access that medical record, see the disclosure, and that would put mom at risk. But our brilliant EPIC team figured out how to do this now, so the IPV screening, that medical providers have access to it, court or legal requests have access to it, but patients do not. Patients will never see kind of the screening, which is really great and kind of helping to keep mom safe. And then if they screen positive, the patient's referred to behavioral health. This is kind of what it looks like. So we asked, again, these are a validated survey instruments. So how often does your partner physically hurt you? How often does your partner insult or talk down to you? How often does your partner threaten you with physical harm? How often does your partner scream or curse at you? How often do you make decisions on how family money is spent? And then we had that kind of couple sentences in the beginning where, again, we're trying to normalize it. We're trying to show the patients we care, and we're telling them what's going to happen if they say yes before we ask a single screening question. And again, so that went live April 23rd, so we don't have data back yet whether or not, hopefully I'm not back here next year saying, and everything was a dud, we're back to the drawing board, but we might, we'll have to see. And then 2 other, so there at Texas Children's, we have this kind of quality improvement core that I'm participating in this summer, and we are going to be looking at IPV screening in the pavilion. Interestingly enough, we have a really high screening rate. 88% of moms that deliver at our hospitals are screened for IPV. However, our disclosure rate is currently 0.4%, which makes me think we're probably not following best practices and we're not following any of the advice that our survivors told us. So we're going to be working to see whether or not we can improve there. And then we are actually going to be adding IPV screening to our emergency room. What's going to be interesting here is it's not going to be done by the medical assistants or the nurses. It's going to be done by a resource coordinator, meaning her entire job is she's screening for food insecurity, she's screening for IPV, and then she's helping patients to kind of figure out if it's an unneeded ER utilization, how they can help address the issues that put them in the ER. So that's going to be a different model where that's a community health worker's entire jobs around screening for social determinants of health and responding to seeing whether or not that impacts rates. And I'm just about out of time. Here again, National Domestic Violence Hotline. Again, if this triggered anything, they can connect you with all the local resources if needed. And then just kind of in conclusion, as we kind of think about these social determinants of health and health, we have prevention, primary prevention, and screening, the secondary prevention and treatment and resources. And as we kind of move between, there's this disconnect between screening and early identification and then the treatment and resources. And it's not just a matter, are we screening and referring? How are we screening and referring? And is that making a difference? And if we're just starting to screen to kind of check that box up, added that to my practice, I'm good, I can go home and sleep really good and feel good about myself, and that's great. We got to start somewhere, right? That really, really is great. But we also have to be looking at the how and making sure that it's in an effective way that is going to benefit our patients. Okay.